what's going on, podcasting world? Welcome back to another episode of the Core Consult RX podcast. I'm here with CKD and also joined by my buddy Aaron Young. Aaron, what's up, man?
How you doing?
Aaron, tell us a little bit about yourself.
I'm a fourth-year pharmacy student, getting close to the end of the tunnel, looking for a job.
Nice. And which rotation are you on right now, just out of curiosity?
Is it the worst one you've had yet?
It's a different one.
Okay.
I've been with this weirdo over at the Feder Health Clinic in downtown Charleston.
Weirdo.
He has a podcast. He talks a lot about diabetes and random stuff.
A lot of random stuff is also thrown in there. Mostly random, actually. So, Aaron, what's your plans after graduate? Because that's coming up May. So you got one rotation left or two?
2 rotations left.
2 rotations left, so home stretch. What's in the cards for you afterwards? What's your career goals?
Currently waiting to see if I match for a managed care residency. Otherwise, thinking maybe looking at specialty pharmacy or something related to that.
Nice.
Cool. So what are we talking about today, Cole?
Before we get started, I feel like it would be judicious to do a little coronavirus update. Only because, listen.
Fine.
Listen.
I'm listening.
Only because right before we recorded, I was watching the press conference.
Mm-hmm.
You're probably at work, so you may not have seen it. But the CDC person was on there, and I guess not a lot has changed since our episode 3 weeks ago, except there's more cases. And the big update, I guess, is that the CDC is like, yeah, there's probably going to be an outbreak in the U.S., so kind of prepare yourselves. But at this point, there isn't. But, I guess if you're in a health system or even in a clinic, you might want to shake off your pandemic preparedness handbooks and come up with a plan.
Well, that's good. That's good. It's important to get everyone kind of in a good mood before we start our topic.
I think that's the best way to do it.
Just prepare yourself for the next bubonic plague.
Mm-hmm.
Basically what Cole's saying.
No, it's still not bad in the U.S. I don't like fear-mongering.
Yeah.
But preparing's not bad.
Yeah. Thanks, news guy.
Yeah. You're welcome.
Fear-mongering. Good word. That's good stuff. And then if you're wondering about updates and stuff, you listen to our podcast from a couple weeks ago, and we have all the different like the CDC links and stuff like that you can check out if you're interested. So today, what are we talking about?
We're not redoing a topic, but we're refreshing and adding to. That's what I like to say.
That's a good way of putting it.
So we're talking about anemia, and in our previous episode from almost a year and a half ago, at least.
I think it was 2018.
We hit on iron deficiency and I believe macrocytic anemia.
Yeah, folate and B12 deficiency.
Folate and B12.
Yeah, so
that
both
was all,
of those.
That was all we hit on. So today we're going to expand a little bit into anemia of chronic disease, and we'll do a little refresher on the various types of anemia. And, prepare yourself. It's going to be good.
Coming at you quick.
Mm-hmm.
So, we were actually joking before we started recording that, because we were looking at the downloads and things, and we saw that this month we've had like 70 downloads on that episode from 2018.
Yeah.
So we were joking there's going to be at least like 70 people that are going to sit there and go, what the heck? I just listened to an episode on anemia. Why are they doing it again?
Wasted my time.
To those people, I say sorry about that.
My valuable commuting time.
So hopefully find some more stuff on the podcast that you like more than anemia twice in a row. But yeah, we're going to kind of go through it. We'll hopefully touch on some definitions and broaden the look, because there's anemia. We could do 1,700 episodes on anemia if we really got into it.
Yeah, we could. And listen to if you've listened to the episodes that we have kind of double dipped into, they're always different. I mean, we always give different information every time.
We try to.
Mostly because we have to refresh ourselves every time we do an episode. So there's always new stuff.
Absolutely. So I guess, where do you want to start, Cole?
Do you want to do a little refresher of iron deficiency and macrocytic before we go into the chronic disease?
Yeah. Let's definitely do that.
Okay. Iron deficiency anemia. So this is, of course, body stores of iron are dropping. Can't support your normal red blood cell production. This can be because of inadequate dietary iron. You don't have adequate absorption of iron in the blood, or there's some type of bleed, whether it's gastrointestinal or otherwise, or even loss of iron in the urine can cause an iron deficiency anemia. So your iron equilibrium is thrown off kilter, and that can be because of multiple mechanisms, but treating it is, if you're not treating the underlying condition, really just involves supplementing with iron.
So the World Health Organization, their kind of like criteria they go with for adults is a hemoglobin level less than 12.5 grams per deciliter. Children, it's less. They usually say less than 11. If I think it's 6 to 14, and then less than 12, or less than 12, 6 to 14, and then younger than that would be less than 11. The U.S., we typically have slightly higher levels. So for males, we would say less than 13.5, females less than 12.5. And the other thing too that was kind of interesting was there's some data that will show that people who live obviously at higher elevation seem to have a little bit better levels. I've seen that. You hear about athletes and stuff trying to train at elevation to improve their cardiovascular abilities before an event. So that's kind of interesting.
Is that legal? And is the blood doping when like you store up that blood that you built up while you're up there, and then when you come back down, you like supplement with that blood? Is that what blood doping is?
So when they talk about blood doping, like usually they're talking about using like erythropoietin or something like that.
Like you're literally stimulating.
Oh yeah.
Okay.
So the blood.
The only knowledge I have is like what people would tell me when I was in like middle school about what it was. You know?
There's a lot of knowledge around blood doping in middle schools nowadays. It's crazy.
I think there is.
But as far as I know, I don't know of any sports that have actually like made it illegal to train at altitude.
Just go to Colorado and run around up in Denver or something.
And I think they can even use, like, I want to say it was Michael Phelps when he was training for Aaron's. We used to be a collegiate swimmer, so he would actually know this better. But I think Michael Phelps was actually using like like one of those chambers or whatever to do like sleeping in like a bariatric chamber or something.
I remember him sleeping in hyperbaric chamber, or I think I saw a video of him swimming in like a pool with a bubble over it, almost to increase, or I guess suck out
the oxygen,
decrease the oxygen content in the air over the pool, so that it would simulate being in altitude without actually having to travel to the mountains or something.
So did you ever sleep in a hyperbaric chamber?
No, I like to breathe.
Nice. Yeah, I do too.
I remember those training masks they used to have?
Yeah. Oh,
they still have them.
People still run around with those things on.
Oh, goodness. If you do that, please stop. But they had the one that looks like a ninja mask instead of like the World War I gas mask they used to have. Yeah. But so I put one of those on one day. I don't know if you've ever actually tried one, but it's great because if you try to run in one, it literally just feels like you're suffocating to death while you're running. It's the most miserable thing you can ever put in your face.
I love when I'm at the gym and I just see somebody like curling 12s and he's got one of those on, you know.
It's not the move.
No.
If you're doing that, I'm serious. You just reevaluate and maybe consider.
Not to act like I go to the gym all the time or anything. I actually currently have no gym membership, so.
Oh my gosh.
We're working on a home gym.
Well, you look great.
I appreciate that. I'm no collegiate swimmer.
That's true. No, I'm just kidding.
Oh, it's very true.
So,
these arms.
Look at these things. These aren't doing the butterfly stroke.
these lats. Come on.
So can I interpret this elevation in normal hemoglobin level to mean that listeners in, say, Denver or somewhere of a higher elevation would expect their average patient's hemoglobin levels to be a little higher?
Could be. I don't know that clinically that they would adjust anything because of that, but yeah, maybe. Don't ask me. I don't live in Denver.
Definitely don't ask Cole. No, so anyways, that was a huge tangent that I got on.
So other things with iron deficiency anemia, you were talking about labs, other useful labs. So you're going to get a CBC, of course, that's going to involve that. You might want to get a serum iron, a TIBC, which is the total iron binding capacity. You're going to need a serum ferritin, evaluate for hemoglobinuria, pulmonary hemosiderosis, also reticulocyte hemoglobin content, those sorts of things. Those are other tests that might come in handy. As far as what you would expect to see on a CBC with iron deficiency anemia, you'll probably see a low MCV and a low MCHC. So MCV is the mean corpuscular volume. I had trouble pronouncing things in episode 39 a year and a half ago. And then MCHC is the mean corpuscular hemoglobin concentration. Also, elevated platelet count in many cases, and normal or elevated white blood cell count.
Yeah, and I know, I mean, there's lots of ways, obviously, to kind of interpret different types of anemia and figure out what's going on. But one of the things that I kind of look at first, once you've established the fact that their hemoglobin levels are low, is looking at the MCV itself and seeing, if we would expect the normal range, depending on the reference you're looking at. Some of them say 80 to 100, some say like 84 to 96. But basically, when you go below that normal range, you're looking at usually a more iron deficiency type anemia. There's some other things it could be as well, but that usually is kind of where you're thinking is the iron deficiency. If it's normal, then there's some other options. It could be there's potentially chronic disease and some other things. And then if it's higher than that, then that's more of your macrocytic anemia, which we're going to get into, and that's more the B12, folate, things like that.
Right.
So MCV is usually like kind of the first thing that can give you some insight as to which direction you need to go. All right.
Yeah. So what are the patients going to look like? Sadly, they will probably give the very non-specific complaint of fatigue or just diminished capability to perform labor or perform activities of daily living. They may have leg cramps. Sometimes they crave ice, which we talked about in the previous episode. So they just might want to suck it or chew it, or they might even crave cold celery or other cold vegetables. They might have an intolerance to cold. They may get infections a little more easy. Stuff like that might point you towards throwing this on your differential.
Yeah, and so Cole mentioned like the iron levels. Obviously, we would expect serum iron to be decreased in these patients, and total iron binding capacity potentially to be increased. And then ferritin levels is another one that we would typically in true iron deficiency anemia would expect it to be decreased because that's kind of like your iron stores. And so once you've sort of depleted your regular iron supply, then you start depleting your iron stores, and that brings that ferritin level down.
And because of that, you'll have an elevated TIBC, which would be the iron binding capacity.
Right. And that's going to be important when we get into like more of like the anemia due to inflammation or chronic disease is going to be looking at that ferritin level. So we'll get back to that in a second, but that's one way that we can kind of differentiate between the two.
Right. So if they have normal ferritin, it's probably something else.
Right. So when you are treating iron deficiency anemia, it's obviously typical to start with just regular oral iron supplements. So, the ferrous sulfate is the one we've all seen before. Ideally, we would think like 100 to 200 milligrams of elemental iron per day. Now, that being said, that might be easier to get to in theory versus actually giving someone a dose of ferrous sulfate 2 or 3 times a day, because it can be really hard on the stomach, causes constipation, irritation in the stomach. So, when we see ferrous sulfate, we're thinking, even though it's 325 milligrams, that's the salt form.
Right.
And so the elemental iron of that is only about 65 milligrams of elemental iron. So you're giving it about 3 times a day to get that 200 milligram replenishment. You're usually having to do that for about 3 to 6 months to actually replenish the stores. So ferrous fumarate, ferrous gluconate, those are other common forms that are available over the counter. There's also things like carbonyl iron, which is Ferrolet 90, I think is the brand name for that one. There's polysaccharide iron complex. They call that one new iron, the NU-iron. Real fancy.
Real fancy.
And I think the main focus of those is to basically, they were trying to make iron supplements that had less GI side effects.
Right.
That's their big claims to fame. We also have slow FE.
I was going to say, that's the common one you see over the counter. Yeah.
And when you look at like the stats, I mean, there's the cost, that those other iron, the prescription irons have along with them, like the new iron, are usually, and I guess in my opinion, would kind of offset the potential benefit that they have.
Right.
They're not necessarily that much more, or not that much less GI side effects with those particular drugs.
Right. And some people, they say take it with food because that helps with GI, but it can inhibit absorption of iron as well. So kind of got to take that with a grain of salt.
Yeah.
Or don't take it with salt because, empty stomach.
Right. Exactly. Yeah. So definitely ideally on an empty stomach. And then also too, one thing that can help absorption, because iron needs an acidic environment to actually be absorbed. So giving it with either vitamin C or even like something like orange juice, the ascorbic acid, where vitamin C can actually increase the acidity enough to increase the absorption. So that's one of the things that they'll do sometimes in order to get that. Also separating it from like your antacids, your H2 blockers, giving it several hours on either side, and so the iron's not being inhibited by one of the antacids.
Right.
So there is a new, fairly new iron supplement. I don't think it's actually it's actually available on the market yet, but it is FDA approved, called Acrofer.
Okay.
Have you seen that at all?
I have not.
Ferric maltol is the actual name of it, and it was approved in July of 2019, but it's still not available from what I've been able to see. And it's a non-salt oral formulation of ferric iron. And basically, when you look at the GI side effects of it, so for example, constipation, you had 4% with ferric maltol versus anywhere from 10 to 39% with ferrous sulfate, depending on the study. So again, their big thing is that it's going to decrease those GI side effects and hopefully increase compliance and all that. I don't know what the price is going to be. I actually tried to look this up and couldn't find a price. So
I guess if it's not being marketed yet.
Yeah, it'd be interesting to see what that price tag is, because if it's really high, insurance companies, I doubt, will be jumping to pay for it.
Speaking of that, you know how there was a law passed, I think it was last year or 2 years ago, where on medicine commercials, they had to show the price of the drug, like the list price at the end. They've totally gotten around that by saying, like, you pay as little as $5 with this copay card, so they never show the price. I remember I think it was an Eliquis commercial where they did list the price, and I thought that was super interesting, so I took a picture of it. The next day, they had the same commercial, and right at the end, it was just like, pay no more than $5 with the copay card.
They got the copay card going. Mm-hmm. Perfect.
Yeah.
That's crazy. So oral iron is obviously the go-to, but if that doesn't work, then we have to go IV iron, parental iron.
Right.
This is going to be something that is going to be a lot more, cumbersome for a patient, because you're going to have to go to the clinic, you have to get infusions. Sometimes it's a dosing schedule that you have to get done. Then you have to also worry about iron toxicities and the other adverse effects. But there is several different options available. The one that is, I guess, if you look at like UpToDate and some of those other things, the one that seems to be a favorite amongst a lot of clinics is the iron-dextran complex. And that's cheaper than other formulations as well. The one thing to kind of keep in mind with that is, so several of these have the potential to have like anaphylactic reactions with them. However, the only actual IV iron that is like required to have a test dose is that iron-dextran complex.
InFed. Brand name.
So you give this test dose, pretty small, I think it's like 25 milligrams of it, and basically wait and see, make sure they don't have any kind of a reaction, and then once you give that test dose, then you can go ahead and give the actual full infusion.
Right.
So there was another iron, IV iron that was approved last month in January called ferric deresomultose.
Nice.
Or monoferric.
I like that one, monoferric.
Yeah. And so this is like the first quote-unquote FDA-approved one-dose formulation. So that's, their big claim to fame. The problem with that, though, is others are already being used off-label as single-dose regimens. So this one's just actually in the labeled indication to be able to give as a one-dose thing.
Right. It is an iron carbohydrate oligosaccharide that releases iron, binds to transferrin for transport to erythroid precursor cells incorporated into hemoglobin. And I guess it's just, I don't know if it acts over a long period of time or if it just gives you enough iron to be good to go. But yeah, very effective, it looks like.
Now, because of the potential infusion reactions, some clinics you may see that will kind of pre-treat or pre-medicate for infusion reactions. It's going to be really hit or miss depending on which clinic you're at. The UpToDate authors that talk about iron-deficiency anemia basically say that the only time they ever pre-treat is with asthma, patients with multiple drug allergies, patients with some kind of like inflammatory arthritis condition, and they use methylprednisolone. They never actually use diphenhydramine, so they just give the steroid and then give the infusion. But other places, I'm sure, will try diphenhydramine as well, but they don't recommend it. But yeah, so iron toxicity is the big thing to kind of keep an eye on as well. If that happens, you have to give a chelating agent basically and get the iron back out of the system.
Right.
get the iron stores replenished.
Now we're doing the opposite
and then
thing.
get it back out again because you now cause toxicity. Perfect.
Yeah. You really want to reserve the last option is packed red blood cells or transfusion, which you really want to reserve for patients who have like a significant bleed or they're in danger of hypoxia or some type of coronary insufficiency. So that's more an emergent acute situation.
Yeah. All right. So that's kind of that sort of iron deficiency. When the MCV is below the 80, menocytic anemia. So let's talk about macrocytic.
Sure.
Again, we talked about this in the other podcast, so I won't go into too much detail. But basically, we can kind of break it down two different ways. Once you get to macrocytic anemia, you can talk about megaloblastic, which is where the anemia is coming from some sort of like an abnormal DNA metabolism that's going to cause that decrease in B12 levels or folate levels. Now that could be from several different reasons. So if you think of like the auto antibody issue where your antibodies attack your intrinsic factor and disrupt that, and you lower your intrinsic factor from that, and you can't absorb B12 from your diet because of that. That's where you get your pernicious anemia from. And then it could be from other issues as well. But then we also have like the non-megaloblastic, which is more so when you have like this increased red cell surface membrane area. And that could be from several different things. I mean, alcoholism can cause that. It can be from like uncontrolled COPD. There's lots of different things, accelerated erythropoiesis. But usually the one we think about like macrocytic, a lot of times I guess more commonly we'll see like a more megaloblastic B12 deficiency, folate deficiency. And so thinking about like B12 and folate, they do work very closely together as far as the synthesis of those building blocks, if you will, for DNA, RNA, those base pairs. And so they are essential for kind of maintaining that integrity of not just the DNA synthesis, but also like the neurological system as well. And so they play a role in fatty acid biosynthesis, energy production, all kinds of things. And, the actual, production of them or their use in those base pairs and the different enzymes and stuff that are involved with that DNA synthesis is pretty closely intertwined. And so a lot of times they will have kind of the same, I guess, presentation. One of the quickest ways to be able to tell the difference between the two is because not just looking at the low serum levels of B12 or folate itself, but one of the first kind of levels that you can check that will change when you start moving towards this macrocytic anemia is your homocysteine levels and your methylmalonic acid levels. So those are the first two. So if you kind of got someone that's kind of like teetering on the edge of like normal and low B12 or folate, then definitely check homocysteine and MMA levels.
Right.
And you can hopefully be able to determine. And what's interesting is elevated. So they'll both be elevated. However, if elevated MMA is found, that's actually indicative of B12 specifically. So folate doesn't actually have anything to do with that particular. Homocysteine affects both, but the MMA is only affected by or only affects B12.
Right.
So if both are elevated, then it's most likely a B12 deficiency.
Right.
Or it could be both together.
It could be. Yeah, you talked about some causes of B12 deficiency. With folate, generally we get enough folate in our diet, but folates are very thermolabile. So excessive heating can cause an activation of folate, especially when foods are excessively diluted in water. So generally, our diet is going to be sufficient for folate, but alternative diets may contain little folate, and you might see that. There's also conditions or situations where there's an increased need for folate. So one that most people think of is pregnancy, especially in the first trimester. Folate supplementation is very important. To prevent spina bifida, I believe.
Mm-hmm. Yeah, and basically folate's involved directly with that neural tube formation. So yeah, a lot of and they will even recommend females that are of reproductive age basically taking folate because a lot of times you don't realize you're pregnant until a couple weeks in or even months in, and so they want to make sure that as much as possible you kind of catch that whole first trimester and get adequate folate levels.
Exactly. So pregnancy, lactation, even rapid growth in pediatrics, also dialysis or psoriasis, or exfoliative dermatitis. All of those can cause an increased demand for folate and potentially lead to folate deficiency. So it needs to be treated.
Treatment's fairly easy with that, usually oral folate.
Right.
I think there is an injectable folate that's still available. I've never seen that actually used. I'm not really sure what the benefit of that would be. But usually oral folate's plenty good enough.
Another situation I can think of where you would need folate supplementation is with certain drugs like methotrexate.
Methotrexate.
Always comes along with a follow it with folate because it will cause it's an anti-folate. So it's going to cause folate deficiency. You need to supplement.
As far as B12 deficiency, usually it's as simple as taking an oral agent. You can also use injectable. And now they've gotten real fancy where they have like sublingual liquids and lozenges that you can use. There's also a nasal solution.
Yes.
Basketball. Mm-hmm. Yeah, I mean, I'd be very curious to see why you need to.
Well, it's kind of like the people who don't want to get the flu shot, so they get the nasal mist, right? They don't want to stick themselves with the B12 injection once a month, so they're like, I'll just spray it up my nose, I guess.
I get that.
I did do the nasal mist when I was a kid 1 year. Never again. It was the worst. Way worse than a shot.
Way worse.
It feels like after you get it, it's like you have a bad cold for 2 days because there's like nasal drainage, it feels like. Mm-hmm. Yeah, I didn't like it at all.
I think basically, because it's a live virus in that case, but it's been DNA-ally.
Right.
Genetically is what I was trying to say, like a normal, intelligent person.
DNA-ally.
DNA-ally, because I'm a moron. Basically, genetically altered so that if it starts to actually migrate down into the lungs, the body heat, the temperature in the lungs just kills it off. Yeah. Versus natural flu is like, nope, I'm good. I'll settle in nicely here. But yeah, so nasal solutions available. Pretty mild adverse effects with B12. The big thing that I always think about that I think it's kind of overlooked with B12 deficiency is the drugs that can cause that I think all of us see all the time, especially in like more primary care setting, is metformin. Mm-hmm. Can decrease the intrinsic factor levels. So again, you have almost like this pernicious anemia just without the autoantibodies, just metformin doing it. And then omeprazole as well. Yeah. So basically any kind of
any PPI,
any sort of PPI, and in theory, I mean anything that can lower acidity, because you do need an acidic environment, but the PPIs are more permanently lowering the acidity while you're taking it. So it's really more of an issue with that class. But I can't tell you how many times I've seen patients that are on both of those medications, and one of the things to watch out for with that is the way it can kind of show up is all the other signs of anemia, like the fatigue and all that, but B12 is specifically can have some neuropathy effects. And so we often hear someone that has diabetes, especially uncontrolled diabetes, it's like we just automatically assume that that's the reason for it, it's just diabetic neuropathy, but some of it can actually be attributed to those B12 levels deficiencies, and so if we can actually correct that, we can get rid of some of that neuropathy with just a B12 supplement. Yeah,
and B12 in general is important for proper neuronal function, so frequently that's part of the panel that my wife orders, and just to see if they have low B12, because if they do, it's one thing for various neurologic conditions that they would want to make sure is adequate and not below the range before they move on to other treatment.
Yeah. All right, good stuff.
Nice.
So that's a good review of what we talked about last time.
Mm-hmm, good.
So again, sorry for the people who just listened to it. But all right, let's move on a little bit.
Well, I guess maybe if they're going in order, they're still a year and a half behind.
They're going to a year and a half from now and be like, oh, this is a good refresher.
Unless they're one of the bingers, which we don't understand, you crazy people.
It's awesome. Respect. I couldn't listen. If I had to listen to my own voice for more than 5 minutes, I would lose it.
Well, I put you on 2x speed today.
Did you?
You sound really good double speed. I don't. You can't understand a word I'm saying.
But I'm extremely charismatic and articulate.
Great. Yeah.
Amazing.
1.5 is a little easier to listen to.
That's your go-to. Okay.
You remember the people the one comment that said they hate our voices?
Yeah.
Maybe if they listened to it on 2.0,
exactly,
it would have fixed all their problems.
Exactly, because I'm so monotone.
Got it.
But if you put me at 1.5, I go up a solid octave.
Right.
Right.
And then you really get that inflection.
Yeah. What? Come on,
We need to
guys.
find out who wrote that and write them back and be like, hey,
Technology.
we got a solution to your problem.
You need to take
Other than
advantage.
leaving mean comments on our iTunes account.
Take advantage of modern technology before you leave a 3-star. Yeah.
Or a 1-star, whatever that was.
Yeah.
It really hurt our
I think it was
feelings.
a 3-star. It's just a lame comment.
No.
Decent.
Yeah.
Decent.
Decent.
And then like 3 comments up. More than decent. That was the negative. That's
oh
great.
Gosh.
Anyways, we talk about our comments too much.
Yeah, that's because they're hilarious sometimes.
funny.
But all right, so let's talk a little bit about. I guess it's kind of weird because they've changed the wording a little bit. So it used to be anemia
Yeah.
of chronic disease.
Yeah.
Now it's kind of
That was so 2018.
That's so 2018. And then now you have this shift to like anemia of inflammation, which is kind of encompasses chronic disease, as well as like critical care anemia, things like that. I would almost say it even lumps in like chronic kidney disease as
CKD.
well.
Yeah. I still feel like anemia of chronic disease is a better umbrella term, but
I like it better
I'm not an expert.
Right. I don't write the textbooks. I just read them kind of. I skim the
Skim.
textbooks. Yeah. But yeah, no, I mean that's kind of like the new terminology, and so I mentioned it just because I don't want there to be confusion. But basically, it's stemming from the same thing where
Right.
chronic disease, and usually we're thinking of like some kind of like rheumatoid condition. There can be lots of things, CKD obviously.
Any
but-
really inflammatory, infectious condition, malignant disease
Yes.
of a long-standing nature can cause it.
can cause.
But you
this
do frequently think of CKD, but yeah, other things as well.
But that's when what makes it complex is because when we kind of see that the way that kind of looks, and when we run labs and everything, it kind of shows up as just an iron deficiency anemia in a lot of cases. And especially like in CKD, we always are kind of looking at that. Now, if it gets bad enough, then we can move to like those erythropoietin stimulating agents, where the kidneys obviously is where some of that erythropoietin originates from and all that. So as that decreases, you want to increase that level so that you can get your hemoglobin levels back up. And we talked about that in our CKD episode, I believe.
Right.
But one of the things that's interesting with like anemia of inflammation or chronic disease, whatever you want to call it, is yes, your serum iron levels are often low. You may have the same increase in like total iron binding capacity, potentially. But one thing is the ferritin that I mentioned last time. So ferritin with true just plain iron deficiency anemia is going to be low because that's your iron stores. Whereas in inflammation, it's typically going to either be normal or even elevated. And that's because inflammation kind of triggers that. Ferritin has the potential to be like an inflammatory marker, and so it'll actually increase with that.
Right. So if you're looking to classify it this way, it would be considered a normocytic, normochromic anemia, because it's an anemia which, with the average size and hemoglobin content of red blood cells, are within normal limits. So normo in that sense. So it's some underlying condition that's causing the anemia.
Yeah, and so and the reason why I bring that up is because you're going to treat it very similarly as far as replenishing the iron, looking for if it gets bad enough to look at going on erythropoietin even in some cases.
Which seems to be, other than treating the underlying condition, that seems to be the treatment.
Right, and that's the big thing is looking for that ferritin levels, because if you're looking at it just like iron deficiency, yes, you may replenish those iron stores and fix some of the symptoms, but you really want to fix the underlying condition if possible, which means either referring out to rheumatology or whatever's causing the issue, but making sure you're actually fixing that problem so that the anemia resolves after you've replenished those iron stores, and it doesn't just keep happening over and over again.
Yeah, could be various forms of heart disease, could be diabetes, could be IBS or other bowel conditions as well.
Yeah, lots of different things. So making sure you're actually going after the disease is important. Let's see. What else we got on this subject?
A little bit of stats. So in general, anemia in general is more common in women, particularly those in their childbearing years. In the latter decades of life in elderly people, it tends to occur without any particular sex predilection. So whether male or female, you just generally are going to suffer from an anemia more often. But patients with CKD, chronic kidney disease, they are at risk of developing anemia more often in males than females. Although males do generally have higher hemoglobin values, they also have higher rates of CKD. And it looks like the prevalence of anemia is lower in current smokers. which they attribute to a secondary erythrocytosis, interestingly.
Yeah. And so, yeah, there's, and I have a list here too of just some other things that can potentially cause that anemia of inflammation. So tuberculosis can do it. We mentioned rheumatoid stuff, gout, obviously, liver diseases. You mentioned the malignancies. So lots of different things can lead to that. HIV.
Right.
So there's lots of different things that can lead to that chronic anemia of inflammation.
So if you are attacking the underlying condition, and maybe you're at steady state with that, you're just not going to get any better, and they are still anemic, the preferred initial form of therapy in this case would be erythropoiesis stimulating agents like we talked about. Blood transfusions they try to reserve for severe and symptomatic cases. If you're going to use one of these ESAs, in the United States we have epoetin alpha and darbepoetin alpha, which is Aranesp. Generally, they put out different guidance over the last 10 or 13 years as to how far you should increase the hemoglobin. So in 2007, there were a couple studies, the CREATE and the CHOIR studies, where the FDA added a black box warning to the labeling of epoetin alpha specifically, but also darbepoetin, to emphasize that ESAs may increase the risk for serious cardiovascular events and death when they're dosed to achieve a target hemoglobin of greater than 12. So in November 2007, the FDA, the verbatim quote is, ESAs should be used to maintain a hemoglobin level between 10 and 12. So that was the guidance then. In 2011, they abandoned the concept of a target range for hemoglobin levels. Instead, they recommended using the lowest dose of ESAs that you can to sufficiently reduce the need for red blood cell transfusions. So that was the goal, was just to reduce the need for transfusions. In 2012, the KDIGO guidelines put out kind of a different recommendation. So this was more for CKD. They say the hemoglobin level in adult patients with CKD should not be maintained above 11.5, because I was going to put people at risk. So some patients, they said, might have improvements in quality of life with hemoglobins above 11.5. So if you're going to do that, they need to be prepared to accept the risks that comes with, but it should definitely not exceed 13, because that's just going to put them at way higher risk. So in general, if you're using these, you want to keep it below 11.5 per KDIGO guidelines. The FDA, I don't know, they don't seem to take a strong stance on it, but for sure, try to keep it below 12 if possible.
And I've even seen it broken down further, depending on, again, who you're looking at. But in CKD specifically, they'll break it apart as far as patients with CKD on hemodialysis versus not on hemodialysis.
Yeah.
And so sometimes they'll even use a goal sometimes of, where you decrease the dose or stop once you get above 10 in patients with CKD that do not have hemodialysis, and then above 11 with hemodialysis. So, and the reason for that, and, Cole mentioned the studies. So the CHOIR trial in particular is the one I always think about. They compared the two kind of goal levels they had. 13.5 was in one group, and then 11.3 was the average in the other group. When you hit the higher target, basically you got no improvement in quality of life, and you had a statistically significant increased risk for death, MI, and stroke. And so it's interesting because when you try to normalize I always think about almost like A1Cs. When you try to normalize it with medication, you run the risk of causing more harm than you don't get the benefit that we would assume, logically speaking, that you would see. So,
and the way I think about these, at least, I always see in my mind, the higher the hemoglobin is, I just see the blood. It doesn't. I'm sure physiologically it doesn't make sense, but I just see it getting thicker and kind of more clogged, which would lead me to say, oh, going to have a serious cardiovascular event or death because of that. And
if this is an area that kind of interests you, this is kind of a little bit off topic, but the Lance Armstrong stuff, the kind of scandal that came up where him and several of his teammates and whatnot were, or American, I don't know if they're teammates, but whatever you call it in cycling, were using these erythropoietin stimulating agents to kind of boost their ability to ride their bike forever.
When multiple Tour de France.
Yeah. So he was on Joe Rogan's podcast, and they were talking about this, and he was talking about guys having to literally get up in the middle of the night and go ride because they could feel their blood congealing, and it was the craziest thing I've ever listening to him. He was really open about it all, and he was talking about like the whole teams are like I think he was one of the Russian teams, like a lot of their cyclists like were all of a sudden just passing away, and they were like, oh, we don't know what's going on, and you have to give them really high levels of EPO.
Those Russians, man, aren't they like
they'll do anything to win?
Aren't they like barred from this Olympics or something like that?
Yeah.
Are they?
For similar things.
They were for the last one, and all the Olympics that were in, where was it? 26 in Rio, were the Olympic athletes from Russia instead of actually representing Russia. Right.
Interesting.
And then I think that was extended to this Olympics
Was
because of some recent
it's something with drugs.
scandal.
I think it was something with drugs.
Yeah, drugs. Lots of drugs.
All the drugs.
All the drugs in Russia.
But yeah, so if you're interested in that, check out that episode because it's pretty nuts. Listening to him describe it, because the fact that people take this stuff recreationally to improve athletic performance is a little bit crazy.
Yeah, I mean, people do a lot of stuff to improve athletic performance that is not necessarily great for their health.
Like testosterone. So you should maybe check out last week's.
Check out our last episode.
Shameless plug.
Nice. So kind of finishing up here, as far as some complications of anemia of chronic disease and CKD as well. So in a healthy individual, erythropoietin exerts its effects in the bone marrow to help the production of red blood cells, thereby improving oxygen concentration in the blood. So that would relieve the hypoxia. The problem is if you aren't getting that proper response, it's going to lead to anemia and other hypoxic events. I also want to talk a little bit about this cardiorenal syndrome. So you hear this term thrown around a lot, which I did some digging, and it appears to be a relatively recent term. I saw one reference. They referenced Silverberg et al., which was some study. And I looked into it, and I think it is a study that was published in the Bantow Journal from Tel Aviv, the Department of Nephrology and Cardiology, and some guy named Donald Silverberg in 2003. So not even that long ago, he coined this term, cardiorenal syndrome. So it refers to what really is a vicious cycle where decreased kidney function, as seen in chronic kidney disease, leads to decreased erythropoietin production, and then anemia. So that's what we've been talking about. Severe anemia can lead to a compensatory left ventricular hypertrophy. Because of that, so you're going to get heart issues, right? So because of that compensatory left ventricular hypertrophy, it eventually precipitates chronic heart failure, which causes a decline in blood perfusion to the kidneys, resulting in further kidney damage. So it's this crazy cycle that can result from anemia of chronic disease that's going to lead to kidney issues and then lead to heart failure and eventually other organs shutting down because of that. This other study called Levin et al. Estimated that for every 1 gram decrease in hemoglobin concentration, there's an increased 6% risk of left ventricular hypertrophy in patients with CKD. Another study estimated that this 1 gram decrease in hemoglobin translated to a 42% increase in left ventricular dilation in patients with stage 5 chronic kidney disease, so severe chronic kidney disease. Improvement of this is a known benefit of ESAs, so that's interesting. But of course, other cardiovascular risks come along with anemia of chronic disease or CKD. The risk of death from a cardiovascular issue in general also increases with advancing age. The impact of anemia of chronic disease and CKD in the elderly population is extremely significant. It's hard to be understated, but I thought the cardiorenal bit was interesting.
Yeah, for sure. And then, also too, like when you're kind of thinking about anemia in general, there's a lot more than just what we've mentioned as far as the potential diagnosis. There's, aplastic anemia, there's hemolytic anemia, there's obviously sickle cell.
Are you saying that we're going to have to do another anemia episode?
Dude, I'm thinking we need to do a lot more anemia episodes.
Our anemia suite. We'll need to complete our anemia suite.
Cole's all about doing a suite. And instead of calling it a playlist or anything like that, it's a suite, as if we are a software company.
Yeah.
I love it. It sounds very professional.
It's a podcast term.
Is it?
I'm making it one.
Oh,
we're on a podcast.
There you have it, folks.
Get with the program.
Mike. Sorry. My bad. So yeah, we're going to do that. So we'll cut that off as a kind of like a overview now, but then we'll have to get more specific. Maybe we'll do aplastic anemia soon.
Okay.
Yeah. See, there you go. Now you guys who are listening feel like you're a part of our meetings. That's how we come up with.
That's how it goes.
We're ready to go, Aaron.
Aaron saw the real deal before. That's what it is.
That's how we.
That's
come
how
up
the
with
sausage is made, right, Mike?
As
Do
they
you want to
say.
bring up our patient case that we
Oh yeah, that's a good
talked
idea.
about
Oh, y'all got a case?
earlier this week? Yeah,
Nice.
I was creating a patient case for Mike for the blog / his PA students, and I guess I got too creative throughout that process, and I decided to ask, what if this patient were deficient in both iron and vitamin B12? What would that look like for her MCV?
Right, lab-wise.
And we realized we didn't know the answer. We were like, dang it.
As we were sitting there looking at it, and I was like, oh no.
Like this is a case you're presenting to your PA students as a, like they have to
We were
come up
just-
with a solution, or y'all are just spitballing to
We
yourself?
were writing, like he had written up the case because I told him let's come up with one that we could use to help kind of like solidify the ideas. And so he was trying to get at like, coming at looking at the iron deficiency, treating that, and then dealing with the B12 deficiency later. And the way he set it up was great. But then that one stupid question that we had to ask ourselves as far as like what that would look like from an MCV, like would the iron deficiency hit first, so that would make the MCV go low, or would the low and the high cancel it out and it would be normocytic? And so we didn't, and then I'm like, great, you realize what you've done? I was like, we have to go into deep research now. And like, I was like, oh no, look what you did.
So the best that we could tell, and from asking around some clinicians that are professors of mine, it seems that if someone is deficient in both B12 and iron, then those could balance each other out. So you could get a normal MCV on the lab values. Or if you are relatively more deficient in either B12 or iron, then the MCV would swing up or swing down. So that just goes to show if you have symptoms of anemia, you should start running some of those diagnostic lab tests like B12, folate, serum ferritin, just to give you a better picture of what's low and what's not, even if the MCV says everything's good.
So the answer is all the above.
Yeah.
Once your hemoglobin goes
Those are the
low,
easiest
run
questions.
all the stuff. Yeah.
So you spend
easy.
this whole podcast telling people that MCV is a crucial diagnostic criteria, but maybe
thanks.
not.
So there you go.
Yeah.
Just ruined my entire thesis.
Basically, we have no idea what's going on with anybody. So
Just
B12 and
just
iron
give
for
them,
everyone.
Just give them iron. This will be fine.
They'll be okay.
But so we're gonna have that available hopefully this week, and we'll put it up on Medium. So that's a new kick we're on. We came up. The first case we posted was a depression case with some anxiety thrown in there as well, and we based that off of the same algorithm that we based our podcast episode on. But this gives you a little bit more of a clinical picture, so you can kind of work through the case. So if you haven't checked that out yet, it's on Medium. The links to it are on like Facebook and stuff as well. But check that out. Love to hear your feedback as well. And then we'll hopefully get this hematology or anemia case up fairly soon.
Cool.
So that's all I got. Anything else for you, Cole?
That's all I got, man.
Aaron?
Have a good night.
So thank you guys so much for listening. If you do have any questions, emails are below in the show notes. Also, you can use our text platform. Text 415-943-6116, and you'll get like an automatic response. Fill out the information that comes in there. It just goes to me. We're obviously not sharing your information with anybody, and we'll send updates and things like that. So when I was actually developing the case, I sent out the case to all my people on my text platform first before anybody else got to see it. So I got some feedback there. So some exclusive stuff on there. And then, social media, Instagram, Facebook, all that fun stuff. Hit us up on any of those. We'll get back to you as quick as we can. And thank you guys, as always, for listening. We appreciate it greatly. See ya.